You know that moment when a doctor pulls out a stethoscope? It's something we've all seen. But what are they really doing when they examine your chest? Well, it's one of the most fundamental skills in medicine. And in this explainer, we're going to pull back the curtain and demystify what's actually happening, step by step. Okay, let's dive right in.
Oh man, we've all been there, right? You get a cough that just hangs on for weeks, or maybe a wheeze you can't get rid of, or you just feel a little short of breath. It's those super common, totally relatable things that usually send us to the doctor, and they trigger the exact examination we're about to break down.
So these are the classic culprits. A cough that just won't quit, feeling short of breath, having chest pain, or that telltale wheezing sound. And sometimes, it can be something a bit more alarming, like coughing up stuff with a little blood in it. Every single one of these is a clue, a little red flag that tells a doctor, okay, we need to investigate what's going on inside the chest.
Now, before you can investigate anything, you need a map, right? And when it comes to your chest, that map is your anatomy. Understanding this blueprint is absolutely the first step to figuring out where a problem might be hiding.
Think of this as the protective cage for all your important organs. Right there in the center, that's your sternum, or your breastbone. Then you've got the ribs branching off, wrapping around to create the chest wall. And sitting right on top are your clavicles, your collarbones. This is the basic structure that holds everything together. So here's where it gets really clever. To make their map even more detailed, doctors use these imaginary lines. You've got one running right down the middle of your breastbone, the midsternal line, and others dropping down from your collarbones. This lets them be super precise. It turns a vague, "it hurts somewhere in here," into a specific location they can actually write down and track.
You can actually try this on yourself right now. Go ahead, find that little soft spot at the base of your neck. Now slide your finger down just a bit until you feel a hard, bony ridge. Found it? That's called the angle of Louis. Now, if you just move your fingers out to the side from there, bam, you're on your second rib. It's a neat little trick doctors use to get their bearings. And tucked away safely underneath all that bony framework are your lungs. But they aren't just two simple balloons. No, they're divided into sections, or what we call lobes. Your right lung has 3 of them, and the left one has 2. Knowing exactly where each lobe sits helps a doctor pinpoint a problem, like pneumonia, down to a very specific neighborhood.
All right, so we've got the map. The investigation can begin. But it doesn't start with a stethoscope or even a single touch. It starts with a conversation. Your story, what you tell the doctor, provides the first and, honestly, the most critical set of clues.
A doctor is going to ask a whole bunch of questions to start building a picture. They'll want to know, when did this all start? Do you have a history of things like asthma or COPD? What about your lifestyle? Do you smoke, or are you around a lot of dust at work? They might even ask if you've traveled recently or been around sick people. Every single answer helps them start narrowing down the possibilities.
Okay, so let's see how this unfolds. After they've listened to your story, the very next step is just observation. It's amazing how many clues a doctor's trained eye can pick up just by watching you breathe.
So during this quick visual scan, they're looking for really specific things. Is there any bluish color on the lips? That could mean a lack of oxygen. Are you having to use muscles in your neck just to get a breath in? They'll literally count how many breaths you take in a minute and watch to see if the rhythm is steady. This all happens in a few seconds, but it tells them so much.
And the shape of the chest itself, that's another massive clue. On the left, you've got a pretty typical chest profile. But look at the one on the right. See how it's more rounded and expanded? That's called a barrel chest, and it's often a telltale sign of a long-term lung condition like COPD, which can cause air to get trapped inside.
Here's another variation a doctor might spot. This is called pectus excavatum. You can see how the breastbone, the sternum, has a pretty noticeable depression. It kind of looks caved in. And then you have the opposite, pectus carinatum, where the sternum actually sticks forward. Again, these are just more examples of how just looking at someone can provide important pieces of the diagnostic puzzle.
Okay, now we get to the hands-on part. The technical term is palpation, but really it just means using the sense of touch to gather even more detailed info that you just can't see with your eyes.
So to check how well your chest is expanding, a doctor will place their hands on your back just like this, with their thumbs pointing toward the spine. Then they'll just ask you to take a nice deep breath. What are they feeling for? Symmetry. They want to see if both sides of your chest move out equally at the exact same time. And here's why that's so important. If one side moves less than the other, or if it's a little delayed, that's a big deal. That asymmetry can point to a problem on that specific side.
Maybe a blockage in an airway or even scarring on the lung tissue, which is called pulmonary fibrosis.
All right, next up is a test with a really fancy name, Tactile Fremitus. I know, it sounds super complicated, but the idea behind it is actually pretty simple. It's just the medical term for the vibration you can feel on your chest when you talk.
And that brings us to this classic line. I'm sure you've been asked to say it before. But why? Why that number specifically? I promise, it's not just a random choice.
The science here is actually pretty cool. The N sound in 99 creates this perfect low-frequency vibration that travels really clearly from your voice box, down through your lungs, and out to the chest wall. A doctor can feel that vibration with their hands, and if it feels muffled or weak, that could mean there's fluid or a blockage in the way. If it's stronger than usual, it could mean the lung tissue is more solid than it should be.
And of course, it's not just about seeing and feeling. It's also about listening. Even the sound of a cough can be a huge diagnostic clue. This quote is about croup, which is a sickness in kids. And it creates this crazy seal barking sound that is so distinctive, a doctor can sometimes diagnose it just by hearing it over the phone.
So when you put it all together, a lung and thorax exam isn't just one thing. It's this whole multisensory investigation. It starts with listening to your story, then seeing how you breathe, feeling for those physical signs, and finally hearing the sounds inside with the stethoscope, listening for wheezes or crackles. Each step builds on the last to create a really complete picture of what's going on with your lungs.
It's a pretty amazing reminder that our bodies are communicating all the time in all these different ways. So the next time you take a deep breath, just think about that incredible, complex system at work and all the silent stories it might be telling.